Hi, good afternoon. My name is Scott Succo, and I'm the Executive Director of the Liver Coalition of San Diego. And tonight we're going to have a liver virtual roundtable, and the topic is going to be liver cancer. We've got a great speaker, and the timing is perfect because October is for livers. So we're really talking about liver cancer and its impact on our community, not just here in San Diego, but across the country. Our speaker tonight is Dr. Gabriel Schnickel. He is the transplant surgeon with the University of California School of Medicine and also the chair of the Liver Coalition of San Diego's Medical Advisory Council. So he provides leadership to our group and helps us decide where we should put our focus and how we should really prioritize our educational learning agenda for the year. A little bit about the Liver Coalition of San Diego is our mission is to save lives by improving liver health and preventing liver disease through community-based education, linkages to care advocacy, and research programs. I mentioned that October is for livers, so we're not alone in what we're doing today. And we're excited that Sarah's with us today from the Global Liver Institute, and she'll be chiming in as we talk to the doctor and hear what he has to say and ask some questions on how we think preventing and treating liver cancer might look in different communities. But we are not alone in doing this. Throughout the country, members of the Global Liver Institute's Liver Action Network are doing very similar things, as is GLI. So you'll see the different members there. We're joined by Arizona. We've got a group out of New York, and then, of course, Tennessee and Texas. So we're in good company. We're also supported tonight by GRAIL. Tonight's virtual liver roundtable is supported by GRAIL, and we're just very appreciative that they are supporting the work that we're doing to not only identify patients and help provide education, but also to look a little bit on how we might prevent by disease progression with early diagnosis. Tonight's webinar is being recorded and will be available on our website as all of our educational learnings. And this is just a list. I'm not going to go through it all, but you can see there's a lot of different topics. We do rotate them out to make sure that they're current and updated. This is not medical advice. This is just educational. And often this is a great place to start, write down questions that when you go visit your doctor can help guide that discussion that you have. And with that, I'd like to toss it over to Dr. Schnickel, who's going to kind of lead us through the discussion tonight as we discuss liver cancer. And I'm going to stop sharing, doctor, and I think you'll be able to share your screen.
All right. Thanks so much, Scott. I appreciate the introduction. I appreciate the overview of the Liver Coalition and the important work that everyone's doing. Yeah. So I'm going to put this up here. Can everyone see the screen? Okay.
And I probably should mention for folks the conversation, we really want a roundtable to be conversational. So to the extent that, Ben and Michael and Greg want to turn on their cameras and engage in the conversation, you're more than welcome. You can put questions in chat as the doctor leads us through the discussion, or, raise your hand or, just pipe in and let's really have this be interactive. Welcome, Dr. Tran.
All right. So to kind of reiterate what Scott's saying, I really wanted to make this as interactive and as much of a discussion as possible. I've put together some slides to kind of help guide the discussion, but please don't hesitate to jump in and hit on any points that you think are important or questions that you might have. So this is kind of just kind of a way to get the conversation rolling, since we don't have any questions to start with. What I thought we could cover is looking at liver tumors, benign versus malignant, as those are a lot of the patients that we see coming to the office. They might have had an incidentally discovered mass in their liver when they went to the ER for some other indication. And we can talk about the most common forms of liver cancer, metastatic disease, hepatocellular carcinoma, which is probably the biggest focus of our time, cholangiocarcinoma as well, we can talk about the incidence and risk factors involved and the treatment options, and what those might look like for different individuals. So again, to kind of break it down, we know that there's a number of benign lesions that occur in the liver, not just malignant. So someone might come or learn that they have a mass in the liver or a lesion, which is kind of the generic terms that get thrown around. It could be that they had some routine ultrasound or went to the ER for some abdominal pain, got a CAT scan, and now they've learned that they have a mass in the liver or some other kind of lesion that is certainly can be frightening and cause a lot of consternation and concern. And so just to kind of cover some of the things that we see in the hospital or in the clinic that are benign and completely, not generally concerning and require no intervention the vast majority of the times. These are just a few, the most common being a hepatic hemangioma. And you can see the picture I have up on the screen looks very ominous at first glance, this big lesion in the liver, but in fact, that's a hemangioma and is no malignant potential, and there's nothing to do about it the vast majority of the time. We also see frequently hepatocellular adenomas, and sometimes these are, thought to be or are concerned on imaging to be malignant, but malignant lesions, but in fact are just benign lesions. We see much more frequently in women, can be associated with use of over-the-counter contraceptive pills, and hepatic cysts, which are just simple clear fluid clear fluid lesions in the liver that again have no malignant potential and generally warrant no interventions. And then also focal nodular hyperplasia, or FNH, again another benign lesion that we see quite frequently in the general population.
Doctor, how do patients identify that they have these lesions? Like, what are the symptoms, or is it just they're there for another reason and then it's identified?
It's a great question, Scott. What we see most frequently is they present for something else. Perhaps they have some elevated liver tests and or they've had some chronic abdominal pain. Their primary physician might look for or might order an ultrasound or a CAT scan, or they might present to the ER for some kind of generalized pain, and the ER gets an ultrasound. And so they find something on the ultrasound, and usually what happens is they'll get an ultrasound that will lead to a CAT scan that might lead to an MRI. And then they might end up in, a surgeon's office like myself with this, concern for liver lesion, or a hepatologist's office. And the majority of the time they're benign and again require just reassurance. Most of them don't even require any further imaging or follow-up. They're just benign lesions that we find incidentally, not symptomatic.
And a follow-up to that, this is Sarah Mains. Thank you, Dr. Schnickel, for being here. I'm assuming from a benign standpoint, as any cyst would be, but from a liver area, are there lifestyle changes or preventative measures, or is it just like any other benign lesion?
Yeah, that's a great question. Patients will frequently ask, is there anything I can do? Is there any dietary changes I can make? And for cysts or any of these lesions, the answer is no. For adenomas, we might change if they're on hormone therapy, we might change that and follow that to see if there's any change over time. But for the vast majority, there's nothing to do. And again, most of these are symptomatic. So if they present with abdominal pain, it's usually unrelated and the abdominal pain has subsided, and they're left with this, results page that they get from the ER or their doctor's office that says, you have this finding in your liver.
Yes. Thank you.
You bet. Yes, sir.
RB Johnson, I just have a question. Is there any risk with any of these benign lesions in the liver to abdominal trauma?
Yeah, it's a great question and something we hear about quite frequently, RB. For people concerned about bleeding from a hemangioma, because it is a vascular malformation in the liver, there's no intrinsic risk having trauma or no risk of it bleeding or rupturing. The adenoma is a little bit different in the sense if it reaches a certain size, we do worry about the risk of bleeding, and that size is generally 5 centimeters, which is by far and away the majority of lesions are less than 5 centimeters. But when they do get to be that big, we do have to consider an intervention like a surgery, or we can stop estrogen containing medications and they might regress a little bit, but sometimes they do require surgery. For the cyst, no risk of bleeding or rupture there, and all the same holds true for focal nodular hyperplasia. So for the majority of lesions, there's really no risk at all. Adenoma being the one where we do have to be thoughtful about it. All right, I'll go ahead and move on to malignancies or the cancers that was the thrust of the talk here. So when we think about liver cancer, that generic term encompasses a lot of different disease processes. The most common malignancy of the liver is actually cancer that is spread from somewhere else to the liver. And the most common of these is colorectal cancer. And you can see this picture I have up on the screen on the right is metastatic disease from colorectal cancer. But other cancers can also wind up in the liver: breast cancer, esophageal, stomach, pancreatic cancer, lung cancer, kidney and skin cancer, or melanoma. So just about any kind of cancer can end up in the liver, but far and away the majority of these are going to be colorectal cancer. And when we think of metastatic disease and how do we treat that in the liver, the first order of business is usually to address the primary tumor, and then we can consider whether addressing the liver disease is warranted, and that would usually encompass a surgery if we were to address the metastatic disease in the liver after treatment with systemic chemotherapy or other adjunct treatments. And then when we think of true liver cancer or primary hepatic malignancies, those are cancers that arise from cells within the liver. The most common, far and away, is hepatocellular carcinoma, or HCC, much easier to say than a mouthful of hepatocellular carcinoma. And this is simply a cancer that arises from the hepatocytes, which is the primary cell type within the liver. This encompasses just about 85% of all primary liver cancers, so the vast majority. And we see it most commonly in the setting of cirrhosis. So people who have some intrinsic liver disease are at a much higher risk of developing the hepatocellular carcinoma. So when someone comes to the office, to their clinic to see their doctor, and they have a liver mass, this is the thoughtful workup that we need to consider. Obviously, the history and physical, age and gender does impart is important when we consider what the diagnosis is. As we talked about with some of the benign lesions, they're more common in women than in men, and diseases in men might be treated differently than they are in women. Do they have a history of liver disease? Cirrhosis? Do they have a history of viral hepatitis, hepatitis B or hepatitis C? Any history of other autoimmune diseases like primary sclerosing cholangitis or ulcerative colitis, which can be associated with that? What medications are they on that might impart a risk to developing a liver tumor, benign or otherwise? I mentioned over-the-counter pills, hormonal pills for birth control. Family history: is there a family history of liver disease? Whether it's fatty liver disease or We know that hepatitis B it can be transmitted vertically, meaning from mother to child at birth. So it's important to get that family history. Where are they from? We know that certain parts of the world have endemic viral hepatitis. So hepatitis B in certain parts of Asia and Southeast Asia, much more common. And we see that vertical transmission quite a bit. And we look at body habitus. We know that morbid obesity and metabolic syndrome imparts a risk for developing liver disease and therefore liver cancer. And then the physical exam, can you feel a palpable mass? Sometimes patients will come to the office and they actually can feel a mass or even see a mass sometimes on their abdomen because things have progressed without developing any symptoms to that point. And then do they have signs of liver disease? And those are some overt physical signs we see of liver disease. Spidery angiomas on the chest wall, pulmonary erythema, you see red palms in the some of the cirrhotic patients. Clubbing, you can see on the nail beds, you can see evidence of hypoxia, which can be associated with liver disease, meaning low oxygen levels. Do they have ascites? Is there a protuberant belly that has fluid in it from liver disease? Temporal wasting, meaning is their face got thinned out from their liver disease, and scleral icterus, meaning are the eyes yellow? And not infrequently, you'd think people look in the mirror every day, they might see that their eyes have turned yellow. But when you actually spend time looking at the mirror, not that I do this myself, mind you, but you very often, you look at the mirror, but you're not looking at your eyes. You don't look at your own eyes very often, right? And so patients will come in and their eyes are quite yellow and they haven't even noticed. It's their friends and family that end up noticing first of all. So these are some of the things that we think about when someone comes to the office and they have a liver mass. And then the labs, it's important. We're really driven by data. And a lot of this data is the blood work that we get, looking at the liver tests, liver enzymes, their chemistry panel, the kidney function panel, hepatitis panel. We want to test for hepatitis, viral hepatitis B and C. So those are the things that we're looking up. And then, we're really dependent on imaging. And as we talked about before, a lot of people will come with a screening ultrasound or an ultrasound that's been done by their PCP for elevated liver tests. And that's commonly the first test, but it's usually not the best diagnostic test. So from there, we're going to go to what we term cross-sectional imaging, where we're getting a CAT scan or an MRI with contrast that gives us this nice picture that you see here. And these 4 quadrants show the same lesion in different phases on an MRI. And we can be pretty confident about what the diagnosis is if we have a good MRI, because they have very particular features on an MRI that tell us what the lesion is. And so these are how we start to think about determining what the diagnosis is in someone who comes in with a mass in their liver. So getting back to HCC, which is our most common primary liver tumor, cross-sectional imaging is usually diagnostic in people who have intrinsic liver disease. So if a patient has cirrhosis and they have a mass in the liver, we can be quite certain if it meets very particular imaging characteristics that it is a hepatocellular carcinoma. So it's unusual that we actually need to get a biopsy. We can move forward with a treatment plan just based on cross-sectional imaging, a CAT scan or an MRI. So that's really helpful that we don't have to put people through a biopsy the vast majority of the time. So just dive in a little bit more in depth on hepatocellular carcinoma. It's
Doctor,
actually,
I'm
yeah.
wondering is there like with other cancers, there's like staging, and based on the staging, the treatments change. With HCC, is there any this treatment stage based on when it's identified in its course?
Yeah, absolutely. I'm going to get to that a little bit more discreetly. If you can hang on, I think I can answer that pretty clearly, but that is a terrific question, Scott. Thanks for bringing that up. And remind me if I don't answer it in the way that is understandable. So hepatocellular carcinoma, the third leading cause of cancer deaths worldwide. And I think it often gets overlooked you feel like, lung cancer, or breast cancer, and colon cancer get a lot of the headlines. But when we look at worldwide, what is responsible for more loss of life, liver cancer is really top of the list, and something that is definitely preventable in many of these cases, because as we talked about, 85%, a large percentage, the majority of hepatocellular carcinoma, around 85%, occurs in the setting of cirrhosis. So if we can diagnose and prevent liver disease before it gets to that point, we can prevent many of these cancer-related deaths. So the reason we see this rising, and sorry, I didn't hit on the graph here, but you can see the rising trend over time in the cancer deaths secondary to HCC. The incidence rate of HCC is going up worldwide, and the trend would continue. This slide only goes to 2005, but the slope is continuing to rise. And you see that the reason for this is we're seeing a rise in chronic liver disease. This cartoon sketch kind of shows you exactly how that process happens. So we have the injury to the liver here, and that can be hepatitis B or C. It can be alcohol. It can be the metabolic syndrome we associate with fatty liver disease, or the autoimmune hepatitis or PSC. Any of these chronic liver injury, they cause this same process of proliferation from injury, and the liver's ability to regenerate also becomes its Achilles heel in some ways, because you have this cell turnover in this inflammatory state, in this chronic injury state, that leads to genetic instability, and you get then that progresses to hyperplasia within the liver, and then you lose some of this genetic stability here. You can lose a tumor suppressor gene that makes the genome more unstable and unable to correct the errors in the translation of the copying of the DNA. And then you get a cancer, and then one cell becomes 2, becomes 4, becomes 16, and so on. You get this rapid growth, and then you have a cancer. So that same process that leads to cirrhosis, which is irreversible scarring of the liver from chronic injury, also leads to the development of cancer. So we see those things progressing. Yeah, Greg.
Yes, Dr. Schnickel, a couple of quick questions on this piece. With cirrhosis, if you live long enough, is it a matter of not if, but when cancer develops in a cirrhotic liver?
Greg, that's a good question. Certainly, the longer you have cirrhosis, the higher your risk over time, but it's not inevitable. I think in part because most of the cirrhosis that we see is in the older population, and our ability to follow them is only so long because their life expectancy is shortened due to the cirrhosis. So I don't think that's quite true, but certainly the risk goes up the longer you're living with cirrhosis. That's true. Okay,
and one second quick follow-up on that one is if it is caught early enough. For example, I have a family member with cirrhosis who every 6 months has an ultrasound screening and a full blood workup by a hematologist, kind of proactively. what are the options or the outcomes if you catch it very early in a cirrhotic liver versus obviously, we know when you don't catch it early, what happens?
Yeah, terrific question, Greg. And early detection is important in just about every kind of cancer, and very true in liver cancer, and for a number of reasons. One of which is most of these tumors develop without symptoms. Tumors can grow to be incredibly large in size without anyone noticing. The liver continues to function. There's nothing to obstruct like there would be in a colon cancer. There's no palpable mass as there might be in a breast cancer or skin cancer lesion that you could see visibly. So that is why it's critical that every patient that has cirrhosis gets screened for liver cancer on a regular basis in perpetuity. So it can't be just once. It can't be, we do it for 5 years. It has to be indefinitely. As long as they have that cirrhotic liver, they need to have screening. And that screening can be an ultrasound, a CAT scan, or an MRI. What most places will do, what we do at UCSD, is to alternate that. So you might get an ultrasound in 6 months and an MRI 6 months later. So you're getting a high definition look at the liver, alternated with a good, easy, non-invasive, quick test. So those two can alternate, but critical importance of screening. And thanks for bringing that up, Greg, because, patients frequently have to be their own advocate, because not every PCP or people who don't see their doctor regularly, if they do have cirrhosis, need to know that they have to get those screening tests, because if you can catch the cancer early, your options are much more vast than if you catch it late.
Awesome, thank you.
Yeah, as we'll see as we go along here, to again address Scott's point that he made earlier.
Dr. Schnickel, sorry, you're getting a ton of questions right
No,
now.
good.
And
Great.
you might be getting to this slide. I'm interested in hearing your thoughts about the rise that you're seeing based on a specific demographic. Are you noticing that there's a wide increase for the white Caucasian population? I mean, we know that the research states that with Hispanic, Asian, or African specific populations, that's going to be higher. But I was just curious if any of your kind of research or identifying that has switched at all.
Yeah, that's a terrific question, Sarah. Thanks for asking it. This slide shows a little bit about, it addresses that question a little bit. We know that the treatment of hepatitis C has dramatically affected the number of patients that we have progressing to cirrhosis and arresting patients that have cirrhosis with the curing their hepatitis C. So we're seeing a little bit of a shift now, but what we are seeing is a significant growth in hepatocellular carcinoma in the NAFLD, the fatty liver disease population that is progressing to cirrhosis. So to answer your question, we know for sure that fatty liver disease the incidence is increasing significantly in the United States and worldwide. That is not equally true in each demographic. We know that in San Diego, the Hispanic population is at much higher risk of developing fatty liver disease and at a higher risk of developing HCC. So there's unquestionably a higher incidence of HCC in the fatty liver disease Hispanic population, at least in our region, and that's something that everyone needs to be aware of here in San Diego. And I think that holds true for that demographic throughout the United States. But we see that the increasing incidence of NAFLD has resulted in increasing rates of HCC. So that is certainly true. The other trend that we've seen in the post-pandemic era is unfortunately increase in alcohol use disorder and patients that are presenting with advanced liver disease secondary to alcohol. And there's as you increase advanced cirrhosis, you increase the incidence of HCC. So we're seeing a rise there as well. And unfortunately, I think we have good news with hepatitis C, although we need to know, everyone needs to know that just because they've been cured of their hepatitis C does not mean that they have no risk of developing liver cancer, of developing HCC. So even if you have been cured of your hepatitis C with these newer direct-acting antivirals that we see ubiquitously advertised in the media now, you're still at risk, and you still need to get that screening test that Greg was talking about before, with either your ultrasound or your CAT scan or your MRI, and you need to do that routinely. So that's a really important point.
I'm wondering if it's interesting. We're doing a hepatitis C elimination initiative, and we're trying to reach the World Health Organization's targets. And one is to decrease incidence of new chronic infections by 80%. And when a modeling has been done by Dr. Natasha Martin at UCSD, it looks as though if we did a bunch of interventions, we could actually meet that benchmark by 2030. However, the other benchmark was a 65% reduction of HCV mortality by 2030. And if we did all the interventions, we would still not reach that mortality goal. And is it because of what you're talking about, is that the HCV, there's cirrhosis that's happening there that is, if they're not linked to kind of a screening program, that's potentially why? Or what could be some reasons that we were going to reach that?
Yeah, great question, Scott, and thanks for highlighting the Eliminate Hep C initiative. I mean, that's just so important and really critical to our underserved populations in San Diego and throughout the country that don't have access to those very expensive direct-acting antiviral pills. Certainly that is true that we're very good at treating Hep C now, but we're not great at continuing to screen and manage their subsequent liver cancers. So again, the battle is not won just because you've cured your hepatitis C. If you already have the damage done, we still need to screen. We still need to be active at following those patients to make sure they don't develop liver cancer.
Okay, thank you.
So this heat map shows and I think, Sarah, this gets a little bit to your question here. It would be nice if we could break it down, looking at more closely at different states and different regions of the United States. And there may be a map that does that. But this is the proportion of HCC that's attributed to NAFLD, or fatty liver disease. And we just certainly see hot spots, in the US and in Mexico, versus, just to the north in Canada, it's significantly lower. And we know there's different populations in those two states, even though they're geographically very close. And we see here and again, in different parts of the world where it's, 35 to 40%. So not everyone is created equal when it comes to the risk of developing HCC and NAFLD. So different people develop liver disease in different ways. And we need to keep that in mind that, we're not all cookie cutters. We're not all made from the same cloth, and we need to keep that in mind as we treat different populations. So here, if left untreated, hepatocellular carcinoma has a very bleak prognosis, with a 5-year survival, approaching 0. But fortunately, we do have a lot of treatment options. So our current armamentarium for treatment of hepatocellular carcinoma involves surgical resection, removing a portion of the liver, liver transplantation, where we remove the entire liver and replace it with a new liver. What we term local regional therapies, where we're directly treating the tumor with either microwave energy or embolization, meaning cutting off the blood supply, or radiation directly to the tumor, delivered either external beam or internally through radioactive isotopes, coated beads delivered through the arteries. And then we have systemic chemotherapy and newer immunotherapies, which are offering a lot of hope to patients who have unresectable or untreatable advanced liver cancer. So we can talk a little bit about those. As I talked about before, the majority of patients who develop HCC do so in the setting of cirrhosis. So we know that means you have an unhealthy, scarred liver, and there are different degrees of cirrhosis and what we call decompensation. Decompensation meaning that your liver can no longer compensate, your body can't compensate for the demands put on it for the liver. The liver does 500 different jobs, and it can't do those jobs anymore on a daily basis. And so you start to develop symptoms of this liver failure, which can be quite serious. And we see here in this picture, the fluid-filled belly, the muscle wasting, the loss of muscle, and the frailty. And in those patients, that helps us determine whether we can operate on those patients or not. And really, we can offer resection, meaning removing a portion of the liver, only to what we would term well-compensated liver disease patients. So patients who don't have this advanced decompensated liver disease. And in those patients, we still have great options in terms of transplant or local regional, or now some of the more effective systemic therapies. I'll just talk briefly about those. So liver transplantation really offers perhaps the best opportunity at a cure for HCC. The outcomes are really excellent, with a recurrence rate in 5 years of 10%, which is really excellent for when we consider surgical treatment of cancer. This is a bit of a diagram that kind of explains why, because we remove the entire organ, which has the disease, and as we talked about it, that disease involves the entirety of the liver, the cirrhosis, that injury, and that genetic injury within the liver is, it's throughout the liver. So if we replace the whole thing and we make the cuts here, and we replace the blood vessels, the blood supply to the liver, we have really the best cancer operation you can do. Sorry. So we know we can, have tumor-free margins. We treat their underlying liver disease. So this is kind of the gold standard. Unfortunately, we don't have livers available for everyone at this point, and there's just not enough. There's an organ shortage for all organs, whether it's heart, liver, kidney, or lung, and we have many more people waiting than we have organs available. So we have to come up with other potential treatments, and not everyone is a candidate, because we need to make the most out of a limited resource when it comes to transplant. And we have these criteria as what we consider. We have what's called the Milan criteria, and that just means this amount of cancer within the liver, we can transplant those patients and have really good outcomes. If we have more cancer than this, then the risk of it coming back negates the benefit of transplant, and those patients won't be offered a transplant. So the Milan criteria is one tumor that's 5 centimeters or less, or up to 3 tumors, the greatest of which is 3 centimeters in size. And we know that with that, we have really good outcomes. Again, our recurrence rate is 10% at 5 years. So we have this algorithm now where we can think of who should get a resection, meaning who should have part of their liver removed with surgery, versus who should go for having their whole liver removed and replaced. And, you know, all the things that go into consideration here is how advanced is their liver disease? Would they tolerate having a portion removed? Is their liver healthy enough? Is their tumor burden acceptable? So if you have more than one tumor, probably a resection is not on the table. So these are the things we think about when we're thinking about who should get part of their liver removed and who should get a transplant. And then we have other newer treatment options like the immunotherapy has really come online for this patient population only in the past few years. And this map just kind of shows that all the different treatment options that have been looked at that are out there that are still in the clinical trial phase, many of them. And you can see this is the benefit, the response rate here. If you're to the right of the this middle line, then we know that there's a significant benefit and a significant response with those treatments. Oops, sorry. And so some of these new ones, atezolizumab and bevacizumab, there's a lot of hard words here, tongue twisters.
We're glad you're saying it and not us. So you're doing great.
Yeah, is now, you know, been shown to have a really good response rate of 34%, which is really, really exceptional in the oncology world and the cancer world. And with nivolumab, with ipilimumab, these two have become kind of the standard, and pembro and lenvatinib. So, and there are new ones coming out with some regularity that are being trialed now. And these ones that have shown this response rate of 30%, which again is really good, are becoming the standard of care. So it was a lot of years where we had one medication that wasn't very good, called sorafenib. And now we've got all these new ones that are really showing to be of significant benefit. And we've seen some really amazing responses. And we've actually been able to transplant patients or get patients who are considered unresectable down to the point where their tumors have shrunk and they've shown some stability that we can get them to transplant or we can get them to resection. So it's an exciting time, I would say, in the world of liver cancer for those of us who treat it. So to move on with another type of cancer, we won't go nearly as in depth here, but cholangiocarcinoma is the other primary liver cancer that we see most frequently. Whereas hepatocellular carcinoma was a cancer derived from the hepatocytes, the primary liver cell. Cholangiocarcinoma is derived from the bile duct cells. So one of the jobs of the liver is to process bile, which is processed and made synthesized in the smaller cells in the liver. And you can think of it kind of like branches of a thick bushy tree that come together to form these common ducts here to eventually drain into the intestine and deliver bile to the first portion of the small intestine to help us digest fat. And so we can get malignancies, cancers of these bile ducts. And there's two different types that we've how we classify them because we treat them differently. One is what we call hilar or extrahepatic cholangiocarcinoma, and one is within the liver called intrahepatic cholangiocarcinoma. And these two are treated differently, though they both have pretty poor prognosis. This type of cancer we can treat with liver transplant as well. This kind, not so much, but this kind is more amenable. The intrahepatic kind is more amenable to surgical resection. There are some systemic treatments as well, some chemotherapy, but the outcome is not quite as optimistic as it is for hepatocellular carcinoma. And this type we don't see the same influences of intrinsic liver disease. You do see these types of cancers more predominantly in patients who have primary sclerosing cholangitis, PSC. But other than that, there's no correlation with intrinsic liver disease like we see with hepatocellular carcinoma. And this is kind of shows the prognosis. It really depends on the staging, how advanced the stage is, whether it's spread outside of the liver or the bile ducts to lymph nodes and whatnot. But again, you can go from having a very good potential outcome here at an early stage, stage 1, versus a pretty bleak prognosis if you have a more advanced stage. And then to kind of finish up, we can talk a little bit about metastatic colorectal cancer, again, because this is a common liver cancer, a cancer that is spread from colon and rectal cancer to the liver. And we're seeing more and more of this as increasing incidence of colorectal cancer in the United States. And we have a pretty robust treatment plan because we have pretty robust systemic therapies. So because it's a metastatic disease, meaning it's spread from its primary origin in the colon or rectum, it warrants having a systemic treatment, a treatment that treats beyond just the liver, because we know it's escaped from its primary location and traveled through the body to get to the liver. So it needs some treatment that addresses that total body treatment, and that is generally chemotherapy. And there's a lot of different treatment options now, from what you'll hear, FOLFOX or FOLFOXIRI. These are acronyms that describe what chemotherapy drug is used. But the point is that we can get many of these patients to surgery, and that's the ultimate end goal, is to get them to the point where we can try and remove all the evidence of disease that they have within the liver, in addition to removing their primary tumor with a colorectal surgeon. And some of the risk factors we see is time, to tell us what the prognosis is for these folks. There are things like how long was it in between the primary cancer and when it shows up in the liver, and whether it happens at the same time or whether it's been a year or 2 years. And then some of the tumor markers, which you'll hear CEA level, you hear that a lot. And then how many tumors you might have, those kinds of things show up a lot in these predictive models. And then just to kind of end on a note of the options that are available, we can be very aggressive at surgically removing these. We can even do what we call a staged operation, where we have someone who's got tumors on both sides of their liver. And normally you can't take out both sides of a liver because you'll be left with no liver. And we can because the liver has the capacity to regenerate. That's not to say it's like a salamander where you chop off the tail and it grows back the way it was. What happens is, if we remove part of the liver, or we remove the blood supply to part of the liver, as you see drawn out here, and trick the liver into thinking we've taken up part of the liver out, what's left gets bigger. It's stimulated to grow. So if we remove the right side, the left side gets bigger, the right side doesn't regrow. And we can take out the majority of the tumors in one operation. Then we can come back, in a couple, 2 or 3 months, and we can, after the liver is recovered, we can go back and take out the rest here. And we're left with no cancer and a very, what originally was a very small remnant liver, but now has grown in size and has all the same functional capacities to survive with.
Wow, it's amazing.
And that really covers it. Yeah.
Yeah, I'm interested. So when we had talked earlier, I'd shared that the American Cancer Society says liver cancer is the fastest growing cause of death by cancer in the United States. So would that be with the liver cancers and not those that have metastasized, or those that have spread, such as
when they
Just
talk
describe
about that.
Yeah,
statistic,
what's
liver
rolled
cancer,
up into that?
yeah, I'm not sure that particular statistic, but we certainly know that both are growing. Hepatocellular carcinoma, primary liver cancer, is growing in significantly. And again, as we talked about, as Sarah mentioned before, as we see chronic liver disease increase, we see there, just by virtue of sheer numbers, we see the increase in the number of patients who have HCC. So, and we also we're seeing an increase in colon cancer and therefore an increase in metastatic cancer to the liver. So at that particular point that you're making, Scott, I'm not sure if they're talking about both of them together, but both are increasing for sure, and HCC is increasing significantly. Yeah.
And it might be just what's reported in the unfortunate situation of a death as the primary, and then would it be colon cancer as a primary and secondary liver, or is it what actually caused the death, which would be liver cancer?
Yeah, on the death certificate, you
yeah.
mean?
Yeah, maybe that's where they pulled that from.
Yeah, it's a good question. The primary should be listed as the cause of death.
And then not where it's spread
So
to.
it would be colon cancer. It would be listed
Gotcha.
as liver cancer. Yeah.
Okay, thanks. Any other questions for the doctor? Hey, Greg.
Hey, well, I've got just a quick one for you, Dr. Schnickel. First of all, thanks. This has been actually fantastic. I support this organization because of the educational outreach and efforts. But to what curiosity is, to what degree is traditional treatment hampered by a cirrhotic liver? So example, I'm using an example because it's a personal example with a family member, MELD score of 7, 5 years abstinence, overall relatively healthy. But with the idea that, to some degree, maybe it's not a matter of if, but when, and found early by either an ultrasound or an MRI. How viable are the options for, I know you need to know a lot more about the patient, but in a scenario similar to that? Sure.
Yeah, terrific question, Greg. So I think there's a couple of things. When we think of treatment, we talked about the different kinds of treatments. So whenever you have a cancer, just about of any kind, removing it is going to be your best opportunity for a durable cure. So in someone who has cirrhosis, it depends on how advanced there is. A MELD of 7, as you said, good chance that they would be able to have a surgical resection, because it sounds like they're what we would term a child's A or a well-compensated cirrhotic. And so you should be able to remove that part of the liver that has the cancer, and they have a good chance at a disease-free survival, long disease-free survival. Some treatment options, resection for sure, is limited by the severity of liver disease.
Right.
Absolutely. Also, even for the advanced cancers that are what we would term unresectable, that can be limited. The immunotherapy and chemotherapy can be limited by how much decompensated. So if you have a MELD score, let's say 20, your options for chemotherapy are going to be limited. The options for liver transplant are still there as long as we're in that tumor burden criteria I mentioned.
Right.
So again, I think the bright spot, as I see it, if you're going to have one in cancer, is that we have a lot of options for HCC. Everything from just a simple resection all the way to a transplant. There's a lot of options on the table, and so for the most people, we can do something. The option for cure is always going to be the best, is either resection or transplant. Those are your best chances at a cure.
Great, thank you. That's
excellent.
Really helpful. Thank you.
Yeah, and it's perfect timing. Dr. Johnson.
Just a quick question. what does age play a role in your, what role does age play in your decision making on surgery?
Sure. Good question, RB. So there's no real age cutoff when we think about transplant. But that being said, once you get up, into the mid to late 70s, the odds of getting transplants are, to be honest, very low. You have to be pretty robust and to get through that operation, and we know from experience that the risk of complications are higher. In terms of surgical resection, I would say it really is more of what Greg was talking about related to, one is comorbidities, as you got to have a healthy heart, healthy lungs, but the status of your liver is going to be the primary driver. Certainly, I've had surgical resections on patients in their mid 80s, and they've done great, even though they've had cirrhosis. So there are still treatment options for most folks, but transplant, in all honesty, even though we don't have a hard stop, becomes less likely as you move to your mid 70s and beyond. Late 60s and early 70s, we can do it, but to be honest, that's the limitation. And then in terms of the immunotherapy and systemic therapy, there's really not a limit there, other than the side effects that can be tolerated by someone that age.
Yes, there we go. Thank you so much, Dr. Schnickel, for leading the discussion. We try to do the virtual roundtable a little bit different from a webinar. So we've been doing a lot of webinars during COVID, so it's nice to mix it up. I appreciate Dr. R.B. Johnson, who serves on our board of directors, for being here. Also, Dr. Tran, who is with the Asian Pacific Health Foundation, for being here. And then Sarah Maines with Global Liver Institute, because it's about partnership to address these increasing rates of liver cancer. We can't do it alone. And it takes our patient community, our caregiver community, and our provider and allied community. So thank you so much for being here. And this will be uploaded to our YouTube channel for future viewing. So with that, I appreciate you and have a good evening.
This has been incredible. Thank you.
Thanks,
Thank you.
everybody. Thanks for
Bye now.
making it interesting and fun.
Thank you so
Thanks.
much.
Great.
Bye now.